Thank you, Chairman Simpson, Ranking Member Pingree, and distinguished members of the subcommittee. Thank you for this opportunity to testify on behalf of the National Indian Health Board and the 575 federally recognized tribal nations we serve. I'm honored to provide testimony on fiscal year 2027 appropriations for the Indian Health Service. My name is A.C. Locklear. I'm a member of the Lumbee Tribe of North Carolina, and I have the honor of serving as the Chief Executive Officer of NIHB, the only national tribally led organization dedicated to advancing the health of all tribal nations. Firstly, thank you for your leadership in providing advance appropriations for IHS. During last year's 43-day shutdown, every IHS facility remained open, every patient received care without delay, and every employee was paid. That stability was only possible because of advance appropriation, and it reflects this subcommittee's longstanding commitment to tribal health. For decades, Congress has provided steady support for IHS through incremental funding increases, and we are grateful. But incremental progress is no longer enough. More substantive investment is needed to address workforce shortages, to modernize infrastructure, and to strengthen care delivery across the system. Through this subcommittee's bipartisan leadership, along with recent actions by the administration, we now have a once-in-a-generation opportunity to move beyond incremental progress and build a health system that is modern, culturally grounded, and capable of delivering the level of care tribal nations deserve. For FY27, NIHB supports the National Tribal Budget Formulation Work Group's recommendation to fund IHS as a mandatory program at $73 billion, including the services, facilities, and improvements necessary to bring Indian health system to the same standards as the broader U.S. healthcare system. The need for modern facilities is extraordinarily pressing. IHS estimates more than $26 billion is required to address facilities construction needs. At current funding levels, that would take over 200 years. We are, however, encouraged by Secretary Kennedy's recent announcement to direct $1 billion in funding towards healthcare facilities construction to begin addressing the long-standing 1993 backlog. This is an important step forward, but requires the partnership of Congress to make this true progress. But the magnitude of the need requires sustained investment, not only in healthcare facilities construction, but also in tribal sanitation facilities construction and facilities maintenance and improvement. At the same time, workforce shortages are also an urgent challenge facing the Indian health system. For the past decade, IHS's vacancy rate has hovered between 20 and 30%, leaving tribal communities without providers, facilities without administrators, critical services delayed, reimbursement claims unpaid. We appreciate the administration's newly announced hiring initiative and now urge Congress to provide resources necessary to sustain and expand those efforts. Programs like purchase-referred care also remain underfunded and understaffed, forcing tribal nations to delay or deny access to specialty care, an outcome that's both preventable and unacceptable. Modernization of the IHS must also include critical investment in health information technology. NIHB requests that Congress fully fund the implementation of a modern electronic health records, or EHR, system. Recent federal estimates place the total cost of EHR modernization at approximately $6.2 billion, reflecting the full scope of implementation, including support for tribal nations that have already invested their own systems to upgrade, integrate, and securely connect. This is more than just technology. It's about protecting sensitive data in an increasingly vulnerable system and building infrastructure that is secure, interoperable, and grounded in tribal data sovereignty. Together, this offers us an unprecedented opportunity to finally modernize the Indian health system. If we get this right, the impact will be profound, improving care coordination, strengthening clinical decision-making, and ultimately leading to better health outcomes across Indian country. However, we recognize the growing contract support costs in Section 105L lease obligations and the limitation of the committee's 302B allocation continue to constrain investments in other critical priority areas. Until Congress moves these accounts to mandatory, we do request heightened support for the remaining IHS line items to ensure that tribal health programs have the resources needed to sustain essential services and meet the growing healthcare needs across Indian country. Behind each of these investments are real patients, families, who rely on the system for care that they cannot access anywhere else. Thank you again for your leadership. With continued partnership from you, your colleagues across the House, engagement from the administration, and the leadership of tribal nations, we have a real opportunity to move beyond incremental progress and to modernize the Indian health system, ensuring the federal government fully meets its trust and treaty responsibilities. NIHB looks forward to working with the subcommittee on these priorities in our testimony. Thank you.
Thank you, AC. Appreciate that. Abigail, you're next.